All right, December 10th here in the US. Another Q&A session. Dr. Dutton, welcome, and others. Let's go through the questions.
Okay, we've got a few questions today, so let's see what we are dealing with. I have a 9-year-old who's doing great with his expansion appliances, but the parents have suddenly decided to stop with me and follow up with another provider. No reason, no warning. Only explanation I have is they are burnt out. I started 2 years ago with online OMT, then Vivos, then Tanner, then stage 1. Anyway, can you advise me on what to advise them to do other than stop turning the appliances? Since one won't bring a patient in for me to adjust the wires, should I tell them to stop wearing it completely? I already sent a certified letter stating all the risks of stopping treatment something. Have you had this happen a lot? Um, obviously, you want to see if they can, if you can talk with them to find out what's happened. So it's good to reach out at least to speak over the phone. It's helpful always to find out why. Everything else is a speculation because everyone's different and every situation is different. Uh, so if you have current or recent updated photographs, then you can put together a presentation of where they started and where they are so that they have an idea of what you've been able to do for them. Um, there's been a lot of different appliances, so maybe they feel like your plan is changing too much and they've lost confidence. It's hard to say without more information. As far as what to do now, if they are no longer coming back, then they have to stop wearing all appliances because these are active appliances and they are mid-treatment. So if they're not continuing treatment, then they have to stop wearing the appliances. Does this happen a lot? No. Has it happened previously? Yeah, sure. People people just stop treatment sometimes. Um, the kids don't want to. The parents don't want to keep going. Um, they are happy with how the front teeth look, and they don't care about the back teeth, or it's gotten too hard, or some other family dynamic has changed. Um, so it's very hard to say. There's many different reasons, but certainly reach out and see if they're open to having a chat over the phone, at least to find out what's happened and for you to be able to provide um, some recommendations for the next step, which is obviously to stop wearing the appliances. It's possible that a new provider is always is different. Them looking for a new provider is different to stopping treatment altogether. Normally, looking for a new provider is they've lost confidence in what you're doing. So you'll need to put all your records together anyway, so that you have have a legal defense if they decide to do anything in the way of seeking compensation if they're unhappy, etc. Next question. Can you explain the difference between a conventionally trained orthodontist phase 1 versus postural orthodontic treatment plan? I'd like to explain this simply to parents. My local orthodontist offers a phase 1, which seems to be upper RPE and brackets to straighten the teeth and bond wire to keep incisors aligned until ready for phase 2. So phase 1 is managing space so that the fixed braces phase can run more smoothly. That's the kind of rationale behind conventional phase 1. Phase 1 is generally aimed at correcting cross bites and to hold leeway space if space is tight. The purpose of phase 1 is always as a preparation for the main treatment, which is fixed braces in the teenage years. Postural orthodontics, the treatment that you guys are providing is effectively the same thing, for making sure that there is a better chance of a simpler process into the teenage years. But the primary difference is we are addressing the etiology of malocclusion in addressing the posture. So there's no focus at all on etiology in conventional orthodontics. Our goal is to recognize that posture has a role and making changes to the posture so that growth becomes more favorable, as opposed to growth is unchanged and we're just trying to preserve space. In addition, because we are actively developing the lower arch, we not only are there to correct cross bites, but we're actually changing the arch form so that we have more space to deal with and to use in the next phase. Occasionally, in both circumstances, conventional phase 1 and postural orthodontics, if we develop good space and we have good control of the wires for alignment, and the family works hard on improving the posture, you can avoid a phase 2. Don't forget, you can also put limited fixed braces on the anterior teeth in the same format and tidy up those as well. So you can mix and match techniques to suit your needs. But the primary difference is we're addressing the root cause and we're also developing the lower arch so that we have a greater chance of correcting the problem rather than just managing the problem. Next question. Can you explain how posturing forward in a twin block is different than posturing forward in a stage 3 bi block, other than the twin block not being penalty appliance when the mouth opens? So that's the primary difference. The twin block has no penalty component to stop the posture from being open. Twin block focuses on correcting dental alveolar imbalance via way of class 2 mechanics. Bi block stage 3 enforces a closed mouth resting posture, encourages the child to actively keep a closed posture at rest, and changes the growth vector to be more of a forward rotation. According to my results, there's some skeletal change in the use of stage 3 and 4 appliances, but in the research on twin block, it's been shown to be dental alveolar in nature. Yeah. So the next question is, obviously twin block research has verified that it's only dental alveolar change with no skeletal change, whereas in stage 3 appliance wear, it's still speculation that it's skeletal because there hasn't been a lot of research, and there's certainly no randomized controlled trial research like in twin block. So twin block has been verified to be dental alveolar only with no significant skeletal change, whereas stage 3 appliances has been speculated to have skeletal change. Preliminary data shows that it does have skeletal change, but because it hasn't been randomized in the studies with the prospective trials done on a large scale, then can't say it's any different from a definitive standpoint. Twin block also is not effective in divergent growth patterns. It tends to work best in low angle growth, whereas stage 3 is designed to help control vertical growth patterns. Next question. You mentioned you sell the families your book to use as a guide to retaining their posture. Where can we purchase your book in order to stock them in our offices? So the book was sold through Amazon, through Dr. Khan's Orthodontics company, but I believe it's out of print now and there's no stock left. So the only thing I can recommend is to pass on the free PDF version of the book. So you guys all have access to the PDF via our Straight Teeth Naturally website.
Just another thing, we also have a website, not sure if you're aware, it's called gopex.us, www.gopex.us. People can go there and download the ebook without entering an email. It's just it redirects to a Google Drive. So that's available if you want to share that with them, or you've got a copy and you can just email it to them. So that's something for your consideration.
Yep.
Thanks.
Okay, so next question is In patients with open bites and a class 1 canine relationship and a class 2 molars, when placing a stage 1, is it advisable to use attachments to prevent tongue protrusion? Open bite, skeletal open bite patients tend to have a divergent growth pattern because they have an open mouth resting posture and their tongue sits forward, resting between the front teeth. Very often they have this resting posture because of airway disturbances. There's something that doesn't allow them to rest with their mouth closed and their tongue on the palate. So they have developed a compensation for survival because often it's an airway compromised situation. So the most important management for this is to resolve the airway disorder. If you don't take into consideration why they've got their mouth open with their tongue forward, then putting a tongue tamer or a tongue blocking or a tongue guard component into the appliance may have you end up with a battle for discomfort and survival. So a divergent growth pattern is something that is unlikely to be resolved with something as basic as a stage 1 appliance. If it's a dental open bite, then you're more likely to be able to resolve the issue because the dental open bite is related to a habit, usually a thumb sucking habit, rather than a tongue forward resting habit. So getting rid of the thumb sucking will help. And in those circumstances, you can have the cat wires bent back so that the free end acts like a spike, and that can discourage the patients from sucking their thumb. But it can also prevent the tongue from coming forward as well. But you have to work out whether it's a skeletal open bite or a dental open bite. What is your opinion on appliances that use acrylic occlusal tracks to rotate the mandible and begin closing the bite? So when you put a bite opening a component to your appliances, then so anything that opens the bite, anything that goes onto the occlusal surfaces will open the bite and will rotate the mandible backwards and will increase the class 2. So if it's a low angle class 3 where the mandible is overclosed, then that can be very helpful. So yes, we do that, but closing the bite So when you put an occlusal, um, if you put occlusal coverage, then you'll slightly intrude the areas where you've got in the opposing teeth and allow for some eruption of the anterior regions. But in the case of, yeah. So if you just open the bite in the back, then you'll get a little bit of intrusion in the molar region, and you'll get a little bit of eruption of the anterior region, and you will backward rotate the mandible and get more class 2. So in the circumstance of a class 3 low angle, then you'll bring the incisors back a little bit. But if you are putting occlusal coverage and you intrude the molars and extrude the incisors, then if they're a class 3 low angle, often the lower anteriors are over erupted. So I'm not sure why you would want to close the bite. So a little bit confused as to what you're expecting with occlusal coverage. All right, so just understand occlusal coverage rotates the mandible backwards, intrudes the region where you've opened the bite, and erupts the region that doesn't have the bite coverage. So um, if you understand the mechanism behind that, then you can use it to suit the malocclusion. Um, if you don't understand the mechanism behind it, then you're going to add in unwanted movements. Next question. We can predict growth of children from the cervical spine in the lateral ceph. How do you apply this knowledge in our treatment? Thanks. So we can use the CVM growth of the cervical vertebrae maturity. It's called CVM, cervical vertebrae maturity. And that just tells us, are they prepubertal, are they pubertal, are they postpubertal? It just often it's used to determine how close they are to puberty. Commonly, it's used to determine if you're doing a phase 1 treatment or when it's appropriate to start a phase 2 treatment. From my perspective, I tend not to worry too much about that. I'm focused more on the um, I focus more on the whether it's mixed dentition, early or late, because that tells me how much time I have left in a stable appliance that I can clasp on the ease. Occasionally, if we have a discrepancy between the chronological age and the biological dental age, I might check the CVM to see how far away they are in puberty. But more often than not, I'm not too fussed about using it. But of course, you can assess it very easily to determine where they are in their growth period timeline. What home care system have you found works the best for keeping appliances clean? I have cases where mom is brushing the appliances but still full of tartar. So normally we recommend the parents clean and brush the plates for the patients every night. You can use toothpaste on a brush once a week. Use hot water with dish detergent, and you can also use periodically the retainer cleaning tablets, or the denture cleaning tablets, and soak them and let the uh, um the tablet kind of fizz away and break down the calcium deposits. So, like all things, tartar or calculus forms from a base of plaque. So, if you have calculus, it has to have been preceded by um, plaque. So it just tells you that the plaque isn't being cleaned off. But yeah, I mean, you got to scale it off, and then have the parents take over the plate hygiene to add in those protocols.
Okay, any final questions? We still got a few minutes. But we will wrap up early if there's no other questions. If you want to raise your hand and join the panel and have a conversation, hot seat with Simon. Don't be shy. Um, but I think those are the questions that were submitted. Um, I think we'll be taking a 3-week break over Christmas. I think there'll be one last session next week, and then it will be, you know, January something. Is it 1, 2 January? Can't remember the exact date, 7th or 8th, but we'll put it in. You know, you'll get emails from us, and we'll let you know when the next session will be. But yeah, any other questions? Otherwise, we'll let Simon have an early lunch. Any final questions? Going once, going twice. All right, looks like that's about it, Simon. Thank you very much.
All right, excellent. Thanks, guys.
All right,
We'll
thanks
catch you
everyone.
next week.
Bye.